This was an 11-year-old warm blood mare doing dressage, and she was lame on the left hind on the straight and lunging to the left, and then was moderate on the left hind upper limb flexion, had some pain and thickening in the proximal suspensory area of the left hind leg. Now, these are various blocks that we've done trying to localize where the lameness is, and a low 4-point or distal metatarsal is one that would be above the fetlock joint and would take out the fetlock on down. And so you can see the lameness remained unchanged here. On the deep branch of the lateral plantar nerve, which is one that's fairly specific for the proximal suspensory, we block that. We got a 75% improvement, which is quite a good improvement. And then the horse now became lame on the right hind, and then we blocked the right hind as well. So we did ultrasound now, and what you see on the left, you look at that sloping line, which is the cannon bone, the back of the cannon bone where the proximal suspensory attaches. And what we see is there's a rough and irregular surface there. Doesn't exist here. Both of these are darker. These tendon and ligament areas of the proximal suspensory are darker than what we would like to see. These are transverse ultrasound views, and they're just showing that both of these ligaments, but more the left than the right, are enlarged. And then these are the radiographs of the hock, and showing a little bit of sclerosis at the top of the cannon bone where that proximal suspensory attaches in both right and left. So here's our treatment: 3 shock waves, both hind proximal suspensories, 3-week intervals. We ride walk the horse 3 to 5 times a week, and then we recheck. This horse also had quiet small paddock turnout. If they won't tolerate quiet small paddock turnout and they're running around, then we just give them more ride walk and keep them in the stall after that, if that's what we have to do. We prefer not to do that. Now, we recheck then 30 days following the 3rd shock wave. And what we saw was, the left hind lameness is improved. And both of them are flexing better, but we were concerned based upon our previous x-rays that there was also some low-grade hock arthritis. And so we wanted to get rid of that influence as well, so we could go ahead and say, well, yes, this horse has a hock problem and a proximal suspensory. We need to deal with both of them. And it is not uncommon that you will see the problems concurrently in the same horse.